I would like to introduce you Marjolein Sander. She's a medical doctor and she's now working on her PhD at the Eindhoven Cancer Registry in the Netherlands. And her main topic is the relationship between diabetes and the risk for cancer.
Okay, so thank you for the introduction. Good morning, everyone. I would like to present the results of our study in which we investigated the trends in treatment for colorectal cancer patients with diabetes in the population-based study. So I'd first like to give you some background information. Many studies have shown that colorectal cancer occurs more commonly in patients with diabetes than in the general population. And in our cancer registry, in 2009, 70% of the patients with colorectal cancer had diabetes at diagnosis. And besides an elevated cancer risk, patients with diabetes have worse overall survival as well. And why do they have a worse overall survival? Is it because they are dying of diabetes and its complications, or are they treated differently? Or is there truly an interaction between both diseases? So we now are interested in the treatment differences between patients with and without diabetes. And the data on comorbidity and cancer registry is scarce, but we have the data, so I'm going to show you. So the aim of our study was to describe the changes in treatment over time in colon and rectal cancer patients with diabetes and to investigate the patient and tumor characteristics who are related to these changes. And thereby we would like to evaluate the national treatment guidelines in the Netherlands. So my colleague Yvette van Kestel already mentioned the Eindhoven Cancer Registry this morning. And we use data from the Eindhoven Cancer Registry as well. We included for this study more than 12,000 patients with colon cancer and more than 5,000 patients with rectal cancer between 1995 and 2009. And since 1995, the Eindhoven Cancer Registry registers comorbidity from the medical records according to a slightly adapted version of the Charlson Comorbidity Index. So in this figure, you can see that during our study periods, the prevalence of diabetes increased in both colon and rectal cancer patients. And in colon cancer patients, it increased from 9% to 17%. When we compare patients without diabetes with patients with colon cancer and diabetes, patients with diabetes were about 4 years older, were more often female and had a diagnosis more often 2 or more comorbidities. Furthermore, the stage distribution did not differ, and there were more proximal colon tumors seen in patients with diabetes. When we look at the resection rates in patients with metastatic disease, patients with diabetes had less surgery. When we then look at rectal cancer patients, the results are comparable and the difference as well. However, patients with rectal cancer and diabetes, there was no difference between the two groups according to sex and the resection rates in metastatic disease, while it was in colon cancer. So in this figure, you can see the proportion of patients with stage 3 colon cancer who received chemotherapy. And you can see that the proportion of patients who received chemotherapy is increasing, and it's just according to the period of diagnosis. However, patients with diabetes still receive less chemotherapy, and you can see it's indicated by the stars above the bars. Why are these differences there? and the guideline shows that patients with stage 3 colon cancer, that everyone should receive chemotherapy, and patients who are older or who have comorbidities should receive another type of chemotherapy, but they have to have chemotherapy. So these differences stay, and maybe it's because of the clinician response to the lower life expectancy or the more treatment complications. And when we included this in a multivariate logistic regression analysis, and we included the covariables age, sex, comorbidities, the number of comorbidities, and period of diagnosis, the significant effect of diabetes remained on the receivement of chemotherapy in this group. When we then look at the patients with stage 4 disease and colon cancer, in this case too, the chemotherapy receivement increased, and the differences between patients with and without diabetes remained. And according to the guidelines of colon cancer, we were published in 2008 online. The patients which have a fairly good physical performance and stage 4 disease have to have chemotherapy. But as you can imagine, patients with diabetes have more comorbidities and therefore a lower physical performance. So this could explain the difference. However, when we include this in the same model with the same covariables and multivariate logistic regression analysis, the effect of diabetes did not remain. Then we go to rectal cancer and to stage 2 T3 and 4 disease and to chemoradiation. There was a trend seen according to the proportion of chemoradiation in time. However, there were no significant differences between the two groups. And in 2006, there were 2 studies published in the Netherlands, and they showed that chemoradiation, so the additional chemotherapy, is leading to a lower rate of recurrences. However, there was no effect found on survival, and till now they don't know which group has the most benefit. So that's maybe why it's not that high and there are not so many differences. Radiotherapy and rectal cancer in stage 2 and 3. It increased very strongly over time, and you can see that in the last period, in 2007-2009, 91% of the patients with diabetes received radiotherapy, while it was 87% for patients without diabetes. So it was even more in patients with diabetes. And according to the guideline of rectal cancer, also online since 2008, everyone with a T2 to 4 tumor has to have radiotherapy before surgery. Then stage 4 rectal cancer, and then chemotherapy. You can see an increase in chemotherapy in both groups. And in the last period, you can see that the patients with diabetes, the rates of chemotherapy decreased when you compare it with the period before the last one, while in patients without diabetes, it was even increasing stronger. So, and actually, according to the guidelines, the chemotherapy in this group is also for the patients with a fairly good physical performance. But in elderly patients, there were also good results till now. But in contrast, when we look at radiotherapy in this same group, you can see that in the last period, the patients with diabetes received more radiotherapy. So it looks like that the patients with rectal cancer and metastatic disease and diabetes that received more radiotherapy and less chemotherapy. So, and this is not in the guideline that it should be like this. So the clinician and the decision of the clinician, which is based on clinical experience, plays a major role in this group and also in the other groups. So in summary, the use of chemotherapy increased strongly. However, diabetes patients still receive chemotherapy less frequently. Furthermore, there were similar rates of radiotherapy, and that the explanation could be in the good responses seen in elderly patients with comorbidity, and in the online publishing of the national guideline in the Netherlands, who said that everyone had to have radiotherapy. And furthermore, the rectal cancer patients with metastatic disease and diabetes received more radiotherapy and less chemotherapy. Then our future research, we are going to investigate the effect of the treatment on outcome as well. So maybe the aggressive approach in the diabetes patients, the increasing aggressive approach, does it lead to a better survival as well? Is it a good response of a clinician to give more therapy? And we recently linked the Eindhoven Cancer Registry with pharmacy data. So we used two combined databases. We are now investigating the effects of diabetes medication and especially metformin on survival. And preliminary results are shown as a poster at this conference. So thank you for your attention. Are there any questions?
Thank you very much, Marjolein. I was really wondering, is it really the effect of diabetes, or is it the effect of having more comorbidities? Because in both groups you see that the patients who have diabetes have as well more comorbidities. So if you do your analysis and make groups like one comorbidity or more than one, will you get them the same results?
Yes, in multivariate logistic regression analysis, we included the number of comorbidities as a covariate, and we only saw in stage 3 colon cancer a really significant effect of diabetes still. So, and in stage 4 disease, it's in more studies that you see that then the comorbidities doesn't matter anymore that much, because you already have extensive disease and you have older age. So yes.
Okay. Any questions, Timo?
Yeah, I have actually to the same point, but a little bit broader view. When you report that there is no significant effect, you interpret it that there is no effect. And as we know, that at least the small materials sometimes, and sometimes even other structures in the data, cause that you don't have a significant effect, but you don't give any point estimate of that significant or non-significant effect. So I would strongly urge you to give the relative risks or odds ratios or something like that with confidence intervals. So then you can make a better verdict whether non-significance really means no effect. It doesn't in general mean no effect. You cannot prove the lack of effect by showing that the result is non-significant, because then you would choose very small materials and all of the effects would be non-significant, and you couldn't prove the lack of effects in that way. So better everybody remember to produce these kind of numerical estimates with confidence intervals when you show results.
Yes, thank you.
Question over here.
I have two questions. The first one is that you mentioned that in 2009, 13% of the patients with colorectal cancers had diabetes. What about the general population? How high is then the percentage? Because otherwise we are not knowing if it's higher in patients with colorectal cancer or in the general population. And the second one is that, well, it has a relation with what Sabine asked, but have you done any analysis concerning survival? Because I can imagine that those patients with diabetes who got chemotherapy or radiochemotherapy had a worse survival than those who hadn't got it. Because generally, I think the specialists, they know, together with the patient, if it's better or not to give it. And they are not there just to follow the roadmap of guidelines, but to discuss with the patient. And I've seen no survival analysis at all. Okay, thank you.
Okay, so thank you for your questions. The first one, I think it's, in this group, it's when you compare it to the general population, I think it's doubled or something. But in the general population, it's increasing like the same speed, I think, as it is in this group of patients. And your second question, we did some preliminary survival analysis. However, that is our future research. First, I have to focus on the Metformin paper. But yes, you can see that sometimes it's worse to give chemotherapy. And so that's what we are going to investigate, if it's really good to give more therapy instead of, maybe it's better to just give less in some groups of patients. So we're going to evaluate what we found here with in the paper in which we investigate survival analysis as well. Yes.
Yes. Thank you. Last question, David Brewster.
Thanks. If patients with diabetes are at increased risk of developing colorectal cancer, and given that patients with diabetes are more likely to be under regular surveillance by doctors, why do you think the average age at diagnosis of colon cancer or colorectal cancer in diabetic patients is higher?
In many studies, you see that patients with diabetes and cancer are older than patients who have only cancer. And it is because that diabetes patients are, it's more frequently to have diabetes on an older age. So you have, instead of you have to have one disease, you have two diseases. So yeah, that's why you have it all together on an older age instead of on a younger age. Yes.
Okay,
yes?
thanks.
Okay.
Thank you. I think we continue. Thank you very much, Marjolein.
Okay.
I'm delighted to introduce our next speaker, Dr. Harry Comer, who of course is the hosting this meeting. Dr. Comer is the director of the National Cancer Registry here in Ireland. And that registry was established in 1991 and started collecting data since 1994. Dr. Comer, I have to congratulate him. He's so collaborative and works with lots of different groups internationally and nationally. And really, we're very proud of the work he's done on our cancer registry. The title of his talk today is Quality of Rectal Cancer Surgery and its Relationship to Surgeon and Hospital Caseload, a Population-Based Study.
Thank you very much, Kathy. I would be the one person who arrives here with my presentation on a memory key. What I want to talk to you about today is looking at the effects of caseload on the quality of rectal cancer surgery. There's a general consensus that there is improved quality of surgical outcome with increasing surgical caseload, and this makes intuitive sense when you think that practice would make perfect. But surgical intervention is not the only intervention which determines survival in rectal cancer, and it's not exactly clear why increasing caseload in surgery in hospitals should actually always produce a better outcome. At the same time, it has been shown that some other measures of surgical care, such as complete mesorectal excision, can also influence quality. what we wanted to do was try to link these together and look at the relationship between the quality measures in caseload on the one hand and survival and caseload on the other hand. We worked with the Royal College of Surgeons in Ireland, who are the body responsible for professional standards in surgery, and they were interested in doing an audit of rectal cancer surgery in Ireland at the time. So with their cooperation, all rectal cancer surgeons and general surgeons in Ireland who were doing rectal surgery took part in this audit. It was a retrospective chart-based audit, and the data was extracted from the charts by trained coders about 2 years, a year and a half to 2 years after the original diagnosis. We identified the cases through the National Cancer Registry. The participating surgeons also identified cases to us, and these were checked for validity against the National Cancer Registry. We defined caseload for each surgeon in hospital as the number of rectal cancer cases treated during the period, which was 2007. We looked at the analysis using general linear mixed models, where we nested the surgeon effect within the hospital effect because, to a large extent, they were very highly correlated. We had quite a lot of missing data, which I'll show you in a minute. So we looked at the missing data in two ways. Firstly, assuming that missing meant missing, and secondly, that missing meant that the procedure hadn't been carried out. For instance, with regard to sigmoidoscopy, the fact that there was no information on sigmoidoscopy in the chart would usually meant that sigmoidoscopy hadn't been carried out. In fact, regardless of which way we ran the models, we got very much the same type of result. We audited 95% of the rectal cancers which were diagnosed in Ireland during the period. For the rest, we couldn't find the medical records at the time. 50 hospitals and 86 surgeons took part. There was a bias towards a fairly low workload, and I'll show you that in a moment. The majority of cases had definitive surgery, about 80%. The outcome for the non-surgical cases was quite poor. Only 23% were alive 3 years after diagnosis, which is the maximum period of follow-up we have. The rest of the analysis looks only at the surgical cases. As you can see, there's a lot of heterogeneity in workload, and quite a large number of surgeons, 48 surgeons, saw less than 5 cases during the year. 36 surgeons operated on less than 5 cases during the year. Only 1 surgeon operated on 30 or more cases, so a relatively low workload for the majority of surgeons. Not quite so biased for the hospitals, but again, 12 hospitals surgically treating fewer than 5 cases during the year, and only 2 hospitals treating more than 30 cases during the year. These are the quality measures we looked at. We looked at them in a number of categories, those related to preoperative assessment, and really what I want to do is draw your attention to the very large amount of missing data, which are the white figures here on the right-hand side. So for some items, you can see there was a lot of data missing. This is neoadjuvant therapy. Again, for some of these, particularly radiotherapy, we were missing quite a bit of data. Surgical procedures, mesorectal excision, leaks, and so on. And again, for some of these, there was a huge amount of data which couldn't be retrieved from the records. And finally, we looked at the content of the pathology report and the information that was in the pathology report. Looking at the relationship first between the caseload and the quality measures, these show the odds ratios that this was carried out per additional case treated. So for instance, rigid sigmoidoscopy the odds ratio was about 1.1, that there was more rigid sigmoidoscopy carried out with higher caseload. The dark blue here show those which are statistically significant. So you can see for MRI of rectum or ultrasound of rectum, patients were more likely to have this with higher caseload surgeons. Again, with regard to neoadjuvant therapy, patients were more likely to have neoadjuvant therapy and were more likely to be judged by the surgeon to have total mesorectal excision, where the surgeon had a higher caseload. Again, information was more likely to be present on mesorectal excision in higher caseload surgeons. If we look at the hospital, we see a very similar picture. Again, ultrasound and MRI more likely to be carried out in the busier hospitals. Differently from the surgeons, MDT discussion was more likely in a busier hospital, as one might expect. Again, optimal TME, which is a pathological verification of total mesorectal excision, again more likely in the busier hospitals. And again, as one might hope, pathology reports are more likely to be available in the chart in the busier hospitals. So in general, there was some tendency for these quality measures to be present where surgeon and hospital caseload was higher. You will note in all of these, the confidence intervals are very wide because of the small number of cases that we were able to look at. So from these, in discussions with the surgeon, we drew out 14 measures which we consider to be measures of, definite measures of quality, and constructed an aggregate quality score. And as you can see, if we look at the quality score here and the caseload up along, there is some tendency for the aggregate quality score to be higher in the higher caseload hospitals. However, sometimes statistics can conceal a little bit more than they show, and this is the real data. So as you can see, there's considerable heterogeneity, and although you may say there's a statistical relationship between caseload and quality, on an individual hospital basis, it's quite difficult to perceive that relationship. We also looked to see whether or not these quality measures had an impact on outcome. We first looked at some of the confounders, so we looked at age, stage, and as you can see, again, outcomes much poorer for distance stage. We looked at ASA grade, which is an overall measure of the patient's fitness, and again, as you can see, chances of survival much lower, no difference by gender. And correcting for these, if we look at some of the quality measures again, you can see in general very, very wide confidence intervals. And while some of the tendencies are up and down, in general terms you can see that we couldn't find anything much in the way of a statistical relationship between caseload and quality measures. This was the only one which was actually statistically significant, which was that there was information in the pathological report on the T stage of the tumour. If we look at the relationship between hazard and the overall quality score, you can see for the lower quality, there seems to be a tendency for slightly better outcomes as the quality score gets better. And if we look at the quality score as a single continuous variable, there is a statistically significant relationship, although a fairly poor one, between low hazard and higher quality scores. So what were our conclusions? We concluded there was a weak relationship between caseload and the measures of quality, and this was mostly related to the preoperative assessment of the patient. There was also a weak and not very consistent relationship between the quality measures as we measure them and the outcome. And there was some slight relationship between the overall measure of quality and the hazard ratios. We couldn't find any measurable association between hospital caseload and outcome. This was completely non-statistically significant. But the weakness is that this was a relatively small study with less than 500 patients, and the confidence intervals were very wide. We do note that most of the studies which have reported on volume and outcomes so far have tended to look at inputs, patient inputs, and hospital inputs, and outcomes, and have described these as measures of quality, but in fact have tended to treat the actual process of care as a black box. So the patients come in, they have characteristics, they come out, they survive, they don't survive. We suggest that if we're going to look at volume-outcome relationships in more detail, we need to understand the process of care. We need to understand what goes on inside the black box, because obviously the relationship between volume and outcome is not consistent across hospitals and is not necessarily determined by many of the things which we can actually measure at the moment. And we would suggest that in future, if people look at volume and outcome relationships, and there is a huge literature at this stage, that more attention needs to be paid on a micro level to the process of care and how that is determined by the hospital characteristics. We'd like to thank the College of Surgeons and the surgeons who took part in this, and particularly the coders who extracted the information. And I just leave you with a small quote from Daniel Kahneman on the limitations of our information. Thank you very much.
Any questions? Yes. We have a question here at the front.
Thank you, Harry, for showing us this insignificant study and the very wide confidence limits that must satisfy Hakulinen. Well, Okay, but I have a question because, of course, some value comes out of this study. You have created an average quality score, and you had a long list that was flicking, so we managed to read the first two. Were they in some sort of priority order? Did they all have the same weight? How did you actually maneuver with this average score? Because that's something that could be repeated so we get a simple graph of the quality.
No, we didn't place any weight on them. The list was derived essentially from the quality audit instrument of the Association of Colorectal Surgeons of Great Britain and Ireland. So they have an audit instrument, and we took basically the variables which they consider to be important in audit, and we looked at these, discussed it with the surgeons, and they said, for instance, preoperative chemoradiotherapy was an indicator of high quality, whereas postoperative chemoradiotherapy was not. So it was constructed on the basis of the advice from the surgeons. We didn't weight them because there didn't seem to be any realistic way in which we could actually weight the variables. If we had a much bigger sample, we could possibly weight the variables in terms of their impact on outcome. But as you could see, we couldn't show any significant impact on outcome, so that type of weighting didn't seem to make any sense. The quality score at the moment, I would consider it's a bit arbitrary, and it would need much more development before we could actually say that this is something which could be used, because you know, at the moment, this may well be relevant in Ireland and not relevant in another country in terms of being a measure of quality. But what I was trying to suggest was that it was necessary to try to look at the quality of the process as distinct from the quality of the outcome when we're looking at the impact of volume on the surgical process.
Dr. O'Reilly, a question here in the front.
Sorry, I had the microphone already here,
sorry.
But I don't want to intrude this, but since Hans was citing me also, that I have a little bit more sort of belief in your data than you yourself have. Mm-hmm. And that is because you showed this linear indicator, the linear analysis. You mentioned that there is a little and significant effect. Mm-hmm. But this little effect is, of course, it's between two numerical values, this odds ratio or relative risk, what you show. So, of course, it has to be small. Mm-hmm. If you use the same linear model and take a little bit wider range, that is a kind of a typical range that is in your data, you get a bigger relative risk, and with equally narrow confidence interval. So actually, if you continue your analysis in that way, you will be able to get much more meaningful results. Pick some typical low numerical value and some typically high numerical value, and show the relative risk for that, and with this confidence interval, then using that linear analysis that you have done. So I think that you probably are able to show a little bit better outcomes than you yourself have thought.
Okay, thank you.
I have a microphone here also already.
Sorry, we'll get to you in a second, Dr. O'Reilly. Oh.
Who needs chairs?
Yes.
Hello.
Hi.
Thanks, Harry. That was interesting.
Thanks,
and I think you very clearly pointed out the limitations of small numbers, so thank you for that. I'm reflecting on how we might, in the future, take advantage of the Tumour Registry's research capacity, because, as you and people here from Ireland know, Ireland has now restructured rectal cancer surgery, the vast majority being done in 8 designated cancer centres, and with 4 other centres doing some rectal cancer surgery too that are linked in. And the hypothesis was very much based on the world literature that high-volume expert surgeons tend to use the best techniques and get good results, and having a multidisciplinary team provide the appropriate pre-op advice on neoadjuvant treatment, etc., improve survival. So I'm very interested in you looking at the overall 5-year survival in due course of this cohort of patients, and then perhaps having successive cohorts nationally. So instead of having the worry of small numbers in each center, the bigger national view of trend tracking for rectal cancer surgery, now that the majority of cases are being handled in, I think, a much different way than ever used to happen in the past. We're all expecting that we'll catch up with some of the highly organized mature cancer systems in the world, such as some of the data we've seen Michelle reporting from Australia, Scandinavia, and Canada, that shows about a 10% better 5-year overall survival for colorectal cancer. I haven't seen that pulled out just for rectal. So would your team be interested in pursuing that as another research project, is the question?
Yes.
Thank you.
Can I just say, I suppose in response to that, and also looking at the previous presentations, cancer registries have to make a choice sometimes between doing detailed analysis on the available data, which is usually stage, maybe some comorbidity, age, and that's it, or trying to get real data about what is actually going on, which is very labor intensive, very expensive to do, but actually much more informative about what actually determines the difference between survival and death from cancer. So I would say, I mean, one of my aims in presenting this today is to say, let's not have any more studies looking at age and stage and grade and survival, and let's try to get a little bit more in behind the process. But this requires quite a lot of money and quite a lot of commitment on the clinical side to actually collect this data and to stand over it. And one of our great advantages was that because the surgeons provided this data and abstracted it themselves, they couldn't say, oh, well, this is the cancer registry. They don't know how to interpret this, you know.
You're right. Yeah.
The other thing which actually was very useful was, if I just go back, this was the slide which convinced the surgeons that most of them would have to stop doing rectal surgery. And they agreed among themselves at a meeting in 2009 that it was ridiculous having this number of surgeons doing so few cancer cases. So sometimes even a very simple analysis like this can have a huge educative effect on the clinicians.
And it drove a lot of change. Thank you, Harry.
Thank you.
Jan Willem.
Thank you.
Yes, Jan Willem, last question, please.
I would have also a suggestion to Harry, and following what Dr. Riley said, that doing this cohort-based analysis, you can also avoid, or you can do that in the back room, looking at what's happening in specific hospitals, because in this type of work, it's often very good to honor those who refer the patients in time. And there are, of course, acute patients which may not be able to refer, and sometimes certain surgeons come and operate in other hospitals. So this comparing of hospitals I find in generally rather useless, but in these cohorts you can show that there are improvements or no improvements, and then you can go into details. And that is also working pretty well. Thank you.
Thank you. Thank you. Thank you, Dr. Comer. Our next speaker is Dr. Nanda Kumar. She heads the National Centre for Disease Informatics and Research in Bangalore, India. She's a physician and a pathologist, and she received her MPH in epidemiology from the University of Washington. She also has, he also has fellowships from the IARC and the UICC. And his talk today is on patterns of care and survival in breast cancer, India. Thank you.
Thank you very much. Good morning, everybody. I'm thankful to Michelle Coleman for having sponsored me to be at this meeting and present this talk. We started the National Cancer Registry program under Professor Luthra in 1982, when we had 3 population and 3 hospital-based registries, till we had the gas disaster in Bhopal, when the Bhopal Cancer Registry started, along with that few more. Then in 2001, we had the WHO-sponsored Cancer Atlas project, where 105 centers contributed data. Subsequent to that, as of 2012, under the National Cancer Registry Program Network, we have a network of 27 plus 1 Hyderabad registry, which was sanctioned last week, and 27 plus 1, 28 population-based registries, hospital-based cancer registries 9, the patterns of care and survival study, which I'll be talking about now in this presentation, 17 of them, the Cancer Atlas in the Northeast, about 17, then about 50 centers using our software, HBCR data management software, then the Punjab Atlas, and the Kerala Cancer Atlas, which we are about to commence. So we have a total of 181 centers contributing data to the National Cancer Registry Program. We cover about 16 of the 31 states and union territories of India. Last week, we had a meeting of the directors of the regional cancer centers under the Secretary, Department of Health, and he has said that every regional cancer center should compulsorily start a hospital-based cancer registry, which would evolve into a population-based cancer registry and so on. So this is the kind of informatics and NCRP that we have developed, and the Indian Council of Medical Research has identified this as a top priority program for translation research under NCRP. We have already developed the software programs on Cancer Atlas, patterns of care, so on and so forth. The process of merging of the above, we may not get to the stage where Hans Storm has got into the Danish Cancer Registry, but we are trying to do our best to link up various software modules. We have the data capture modules, both offline and online. Our team, majority of the staff are software personnel. In fact, I lost 48 of them in a mat with average stay of 10 months. But once the recession in the US started, all of them stayed back. So for the past 5 years, I have reasonably stable software staff working with me. We are devising all these modules, including the deduplication modules and the data quality and completeness of coverage. See, as far as the data that comes in, the quality of the data is thoroughly checked as per IARC standards. Only the completeness of the coverage is a challenge. We have tried to develop a software which will show us the decreases in fluctuations and so by various sources of registrations online, and so that the specific population registries could take action. So I'll quickly get into the patterns of care study. Earlier we had this Cancer Atlas project, which was a concept of using a simple 1 to 2 page form and one-time data entry, so on and so forth. The patterns of care and study, we devised a 12-page form standardized after 4 workshops, where all the oncologists, medical, surgical, and radiation oncologists participated and finalized this form. So this is the website that we have. I mean, the main software programs are located in A7 in the poster session. And we have various outputs, but most importantly for this pattern of care study, I would like to point out, see, follow-up is a major weakness of our cancer registries. The rate of passive follow-up is hardly 15%. So we need to pursue the patients actively, and we have developed the software which will give us follow-up alerts and will also trigger SMS to both the patient and the physician. So this is some of the outputs we get. Now coming to the objectives of the study, we wanted to look into the details of clinical stage, types of treatment, stage-based survival, and stage-based treatment as well. These are the 17 centers that are participating in this exercise. And over the past 4 years, we have received data from all these about cancer sites, about 63,309 patients. Now I'm restricting my talk to this breast cancer group from 2006 to 9, where 10,434 patients, which were treated only at the reporting institution, the patterns of care is presented. So this is the 10,434 in the 4-year time period. So we had a 99% microscopic confirmation of breast cancer. I mean, obviously it was an accessible, relatively easily accessible site for taking a biopsy, and of course surgery was also done in quite a few cases. So this is the stage grouping. You will see, I mean, I have not got the slide of cancer cervix. In fact, many more, we have a 15% stage 1 grouping for cancer cervix compared to just 5% for stage 1 breast cancer. This is, of course, a hospital-based data and not a population-based data. And unknown and missing, we had about 2.5% of cases. So this is the waiting time. See, one of the outputs that our software generates is waiting time between date of registration at reporting institution and date of diagnosis. As you see, about 92% of patients, the waiting time was less than a month for diagnosis to take place. Of course, there were a few patients who had a waiting time of over 12 months, which was quite, and we are trying to look into those cases as well. Then this is the waiting time between date of diagnosis and date of commencement of cancer-directed treatment. And as you know, breast cancer is a prolonged multimodality treatment, and we do expect patients to at least complete their treatment in 1 to 3 months. So we found about 93.7% of patients completing the treatment of initial cancer-directed treatment. Of course, hormone therapy has not been included here, and that is included 23%. Then the treatment time itself. The treatment time is spread over a period of almost 12 months, with majority of the patients completing the treatment in 12 months. This is where I said hormone treatment is not included. Then this is the type of treatment that was given, and according to all stages, majority of them received either surgery, majority of them had surgery, but in combination with radiotherapy, chemotherapy, and hormone therapy. I mean, mind you, this is just a preliminary analysis. This is an ongoing study. I haven't done sophisticated survival analysis, which will be done later. Okay, so this is the follow-up. As I told you, follow-up is a huge challenge in our country, and we could know whether patients were alive or dead, which I mean by only demographic follow-up. And clinical follow-up means treating clinician is able to evaluate whether there is recurrence or there is disease-free. So this is the kind of follow-up we had over the 12, 24, and 36 months. And disease-free was about 88% in the 12 months, 90%, and so on and so forth. Total clinical follow-up was this, and recurrence rate was 12%, 9.4%, and 8%. Then this is the survival that we found. This is 86.3 at 12 months, but it drops down to 77.4 and 67.8. And at 36 months, less than 50 years or more than 50 years of age, we did not find too much of a difference. And according to broad type of treatment also, we looked up surgery, radiotherapy, chemotherapy. You find wherever chemotherapy is given, there is probably lesser survival. This is something which we are investigating. And this is stage 2, stage 3, and stage 4. The most important thing, of course, one of the things that we wanted to translate to see whether in our Indian setup, what is the proportion of patients who underwent breast conservative surgery? See, in the Western countries, breast conservative surgery is the normal practice, and it is much beyond the 19.8%, but we looked at according to clinical stage, and we found in stage 1, which should have been about 80% probably in the developed countries, it is about 41.3% is the breast conservative surgery that was practiced. This was the main finding of this preliminary analysis. As I said, I have requested all centers to complete their follow-up of whether it is demographic follow-up or clinical follow-up by 31st December 2011, then we will be able to do the complete survival analysis. With this, I would like to conclude that we are having our 28th annual review meeting at the Regional Cancer Center, Trivandrum. I would request all of whoever is interested to come and participate in this. We have a 2-day workshop, and all the centers that I pointed out earlier will be participating in this program. We had the privilege of having Dr. Callum Moyer and Dr. Hirayama, who started the first annual review meeting in 82-83. Since then, we have been having this every year. The dates are decided in the previous annual review meeting itself. And then the other outcome that has come about is the National Cancer Registry Program, which was a program. It has been made a permanent institute of the Indian Council of Medical Research called the National Center for Disease Informatics and Research. So this is one of the benefits that Cancer Registry has brought to our country. And I have been requested by the research area panel on stroke to commence a national stroke registry as well. And this is the new building that we have in Bangalore, which has housed this entire team of software people as well as our staff. And I thank you for your kind attention. Thank you very much.
Thank you for your presentation. Any questions from the floor? Yes, Dr. Comer.
Thank you very much, Dr. Nandakumar. A microscopic verification rate of 99% is very high. Do you suspect that there may be some patients who are not being picked up by the registration process, perhaps with no surgical intervention, poor prognosis, and so on?
These are data from the hospital-based cancer registry. And many of the centers that we saw many of these centers are regional cancer centers. So if it was a population-based cancer registry, what you say is right. Yeah, microscopic confirmation is about 85 or 90% in a population-based cancer registry. But since this is a population-based, hospital-based cancer registry, and we have taken all patients treated at reporting institution. See, these are patients treated at 10,434 patients having undergone treatment at reporting institution. Whatever patients did not receive treatment, 890, or the prior treatment have been excluded. So there you would get the patients who are not microscopically diagnosed. Thank you.
Yes, a question at the back.
I just want to make a comment on basically breast conservative surgery versus mastectomy. Basically, stage 1 and stage 2 patients can have both kind of a treatment because there is no as such survival improvement. What I would recommend is that when you are doing further research, as you mentioned, that try to look into the comorbid conditions also, because more and more late stages, when even a woman diagnosed with stage 1 and 2 breast cancer, they die because of the other disease. So there's no as such survival difference between those two treatment modalities.
Absolutely. We will be looking into those things. Yeah.
Any last question then? Yes, here.
Thank you very much. Eduardo Laura. Perhaps I misunderstood, but I saw in one of the slides, stage 1, 54% of mastectomies. What kind of mastectomies? I suppose is conserving the muscles.
Yeah.
But if I understood well, which is the reason of such a high percent of
it could
mastectomy?
Yeah, I haven't given the split up of the mastectomy, the type of mastectomy. Any mastectomy was included in that, whether it was modified, except lumpectomy, which was considered a breast conservative surgery, that is included. I would put all other types of surgeries instead of mastectomy in that.
So in India, it's usual to perform for stage 1 the mastectomy in 2000?
Well, this is a new revelation. This is what came out of the discussion. That is exactly why I showed this slide. Why we need to, ICMR is evolving guidelines for various cancer treatments, and the need for doing more breast conservative surgery is something which has come out of this data.
Yes, because Dr.
Yes, it is an important thing. It is an important thing. I agree with you.
In the 70s, Dr. Veronesi showed to the world that the results were the same with just a very little incision and the lymphadenectomy. No? So it's amazing that. Okay, thank you.
Thank you.
Well, one more question and then we'll continue.
Just to add to this point, I think it is the
Yeah.
Perhaps if we had split it into specialized centers which practice breast conservation surgery, I think the results would have been different.
Yeah.
Okay, thank you very much for
Thank
an
you very
excellent
much.
presentation. Thank you. Our next speaker is Dr. Isabel Sorjamkartaram. She received her medical degree from Indonesia University in Jakarta before going to the Netherlands, where she was awarded a PhD in epidemiology. She's using population-based cancer registry data. She looked at a number of different cancer types there. She then did a postdoc at Harvard School of Public Health. She's currently back in Lyon, France at the IARC, and she's a scientist there in the section of cancer information. Her talk today is Disability Adjusted Life Years, Country-Specific Estimates for 27 Cancers in 12 World Regions.
And then I just press to move. Okay. Hello everyone. So today I'm going to present the work that I've been working in the last 2 years. But before going to the work, this is now 5 years since the last meeting. This is the first meeting, the IACR 2007 in Slovenia. And since then, I've been on the quest to find the art of giving a good presentation. Usually I would try to use metaphors, but then it's really difficult to use metaphors or to find good examples for DALY's, Disability Adjusted Life Years. I used usually examples with food. I even once last summer bribed my whole audience with chocolates, but that was not possible, I think, for this audience. And then now that the coffee time is really close, it leaves me to only one last emergency mode style of presentation, which I call Hans style of presentation. So, in describing the burden of cancer, we have been now working a lot in our section in describing the burden using incidence rate, mortality, prevalence, and survival. We have all this data available in our website if you're more interested. But then more and more, with the increasing survival of the cancer patients, there are more and more studies involving the quality of life, as what you will see with the keynote presentation later on from Professor van der Pol. So the aim of this study is to describe the burden of cancer using disability-adjusted life year that links all these indicators together, linking the mortality with morbidity, also adjusting for the quality of life, and we're using disability weights here as a measure of the quality of life. How we calculated the disability-adjusted life year is I'm going to present an illustration here. So let's assume this is the expected life expectancy of one person since birth until the end of life. So when a cancer is diagnosed at some point of that person's life, so the healthy life years can become life with some certain disabilities. When that person dies earlier because of cancer, then the healthy life years or the years with disability is then lost due to premature mortality. So the time in between the incidence of mortality is then captured during the survival, and then during that time then we'll also then adjust using the disability weight that I mentioned before. So all these healthy life years that are lost is what we call disability-adjusted life years. It has two components. The first part is the years of life lost because of disability. And then the second part is the years of life lost because of earlier death, which is YLL and YLD. So the source of data is the 3 R's. I can't get better pictures for the balls than what I have here, but it stands for registry, registry, and registry. These are the data that we needed. For the YLL, it was quite straightforward with the mortality by age. But for calculating the YLD, we had to do a lot of work to get the proportion cure, proportion treated, duration of each disease phase, duration of each treatment, proportion of the patient with sequelae, the disability weights that's related to it, and a lot of expert opinions on the matter. So after a year, when we got our data in and all the input in, this is Joanny, who's working on getting our analysis and our graphs done. She presented to us thousands of data. We have 27 cancer sites. We have 180 countries. She made diagrams, she made box plots, she made world chart and everything. It was a lot of data to work with. Until the 2 men, Max and Freddy, came saying that actually there's only 2 things that you should report, that you can really look in the pattern of all the countries and of all the cancers. So the first one is this one. This is the world map of DALI mapped. So in total, we estimated 169 million of healthy life year lost because of cancer. You see the darker blue is the areas where the disability-adjusted life year is highest, and the lighter blue is where the disability-adjusted life years lowest. You see in Eastern European countries and part of Asia very high DALIs, and then also with some part of the sub-Saharan Africa. The most remarkable pictures here with the YLL is how similar it is with the DALIs. If you see the DALIs and the YLL, there's hardly anything changing, and that is the first point that Max pointed out. If you go on to the YLD, then the picture completely changes with very high burden that's related to the disability that's caused by cancer in higher income countries. So the fact that DALIs and YLL is very similar, more than 90% of the DALI is contributed to the earlier death, suggests that still now the best method to fight or to control for cancer is using prevention. If you see here, this is the leading cancer by country that contribute to DALIs in men. So, for example, you see all the blue color in the map is lung cancer. So lung cancer is still the top contributor to the DALIs, even in the highest income countries. And then you see also liver cancer as the main cancer that contribute to the DALIs. Suggesting again back to the primary prevention and how important it is for us then to fight against cancer. The second pattern that pointed out by Freddy is that we should look at how all the patterns link to the Human Development Index. So here you see the DALI in bars, in red is the YLL, and in yellow is the YLD. The left side with very high is very high HDI country or very high Human Development Index country, and then on the left side then you'll see the countries with the low HDI countries. You see always with any cancer, either with high burden in high income countries or low burden in high income countries, that the yellow bar is always larger in the most in the countries with the highest HDIs. You see it with breast cancer, you see it with prostate cancer and testicular cancer. Again, here you see the same kind of pattern. The proportion of YLL over DALIs indicates prognosis after diagnosis of cancer. So here, all the figures show and point to one thing, that there's poorer prognosis and lower medium HDI countries, which point that we need to increase the equal care and early detection in lower and medium HDI countries. So, to conclude, just coming back to the two main messages, large proportion of the DALYs is still due to premature death from cancer, and the second part is the poorer prognosis, which just point back to the old message, increased prevention and equal access to healthcare. One limitation, as always, data are really limited in the low and middle income country. I see that we have more and more studies, especially from these books, from all these meetings, that I think is really useful for our future studies. But then all the work of the last 2 years finally paid off. We published 2 of our papers. The last one has recently just been accepted, and we're very proud, so hopefully it will be coming out soon. There's the method paper that is already available online, and then there's going to be the description of the study and the results, and as well all the data will be available in Globocan. And finally, I would like to thank all the cancer registry that contributed to the Globocan, but with some special thanks to the cancer registries that contributed even more with comments of the data to all these people. Thank you for the attention.
Any questions? Thank you very much for your presentation. Any questions? It was a fantastic presentation. In terms of using disability-adjusted life years, or do you see its main function in comparing health services and cancer services between countries rather than a tool used in each individual country?
Yeah, it was really, you see that pattern really care that there is lower access to care in the low and middle income countries. And then we're hoping to do more what we call high resolution studies to see with better data, and we're trying to collect better improved data in some of the countries to be able to capture that even better.
Can you say something about the clinical implications of your results within some more higher income country?
I'm going to present another presentation, which is on the ENCR, exactly on that topic, because using the Dutch data, where we have really good staging data, treatment data, where then I think has more clinical implication, and then you're welcome to attend the presentation tomorrow.
Yes, but I think part of the audience is probably not there, so could you... I'm giving out the presentation for tomorrow. Okay. Everybody can, who's not attending tomorrow afternoon, can ask the presentation to Isabel.
There's a question down the back here.
Hello. Can I do a suggestion? Is that you, even with the bad quality of data or the not so good quality of data, that you try to make the impact of society of cancer. So if you say, let's say, there is 168 million years, 168 million years, that you would, for instance, say that is times 5 or 10 or 20 the impact on the environment, or that you try to find some ways, because cancer is not only of impact for those who die, but also for and who suffer from it, from those around.
Agree, Willem. We're working more and more as well on the trying to combine the impact of prevention and then calculate it in terms of benefit and harms lost using the DALYs, because it's really easy to convert the person years into dollars. So it's on the way. It's coming.
Thank you. Any further questions? Yes. Yeah. Final question here at the front. Maybe you'd like to take this mic.
But I can meanwhile comment on Jan Willem that it will then emphasize the rich countries, because the cost, of course, what is lost is much more in the rich countries than in the poor countries. And the human life in principle is equally valuable in the poor country as in the rich country.
Actually, what we saw in our study, it's not true. We see quite similar loss of healthy life years at the end for all cancer combined, also in low and middle income countries. So it's not true that, as already mentioned yesterday, that cancer is only a problem of the high income countries. It's shifting. Yeah.
Okay, thank you. In the interest of time now, we have our coffee break, which is slightly late, but hopefully we'll make up our time later on. Thank you.